Thank you, Tim. Good morning, everyone. Okay, so BCR-ABLI kinase domain mutations are not the only mechanism of resistance to tyrosine kinase inhibitors, and not even the most frequent, yet they are the only actionable one. For these reasons, both the ELN recommendations and the NCCN guidelines recommend to perform BCR-ABLI kinase domain mutation screening in specific cases. According to the ELN, kinase domain mutation screening should be performed at diagnosis only in those patients who present with de novo accelerated phase or blast crisis, and during TKI therapy in all cases with failure and warning, of course, after having excluded non-compliance and drug interactions. The recommended method for BCR-ABLI kinase domain mutation screening was, in those recommendations, conventional Sanger sequencing. But this is just because at that time, nobody could have ever imagined what a revolution the advent of batch-top next-generation sequencers were about to bring in the diagnostic setting in a few years' time. This is the current panorama of all the instruments that have reached the market and are available for routine diagnostic NGS analysis of genes and gene panels. The first clue of the importance and the power of NGS for mutation screening came from the IRON study. A study aimed to assess the technical feasibility of diagnostic NGS and the concordance of results across multiple laboratories. Assays for TAT2, CBOL, and KRAS were the first to be developed in the pilot phase, but many others followed in the second phase of the study, including an assay for BCR-ABLI. In particular, a network of 10 laboratories from 8 countries decided to engage in the standardization and validation of such an assay for BCR-ABLI kinase domain mutation screening, and the results of this effort demonstrated high concordance between Sanger sequencing and NGS results, and that was done in almost 400 samples analyzed in parallel. And we also performed the very first international standardization control round, demonstrating that applying NGS in multiple laboratories could be feasible. The advantages of next-generation sequencing over conventional Sanger sequencing for BCR-ABLI kinase domain mutation screening include greater sensitivity, the possibility to perform a clonal analysis and to discriminate between compound and polyclonal mutations, and the possibility to perform a quantitative analysis and follow the dynamics of mutant populations over time. Is greater sensitivity an advantage from a clinical standpoint? Well, there are several lines of evidence saying yes. Even in the pre-NGS era, the studies from the Australian colleagues had clearly indicated that enhancing sensitivity of detection of 1 to 2 lux using mass spectrometry with lower detection limit ranges between 0.05% and 0.5% may be important in the setting of imatinib-resistant patients. And after entering the NGS era, there have been several studies suggesting that low-burden mutations detectable by NGS only do matter. In this elegant study of the clonal evolution of resistant mutants in relapsed acute myeloid leukemia patients, we can see that low-burden mutant clones detectable by NGS only could have anticipated relapse at the time of hematologic remission of these AML patients. And also in the setting of CLL, we have several studies like this one showing that the subclonal TP53 mutations detectable by NGS only do harbor the same negative prognostic value as clonal mutations at diagnosis detectable by conventional Sanger sequencing, and these are only a couple of examples. What about NGS for BCR-ABLI? What does the literature tell to us? What do we know? Well, we know that for mutations with greater than 15 to 20% abundance, NGS and conventional sequencing results are highly concordant. We know that NGS may detect emerging mutations up to several months earlier, and in a proportion of patients relapse on second-line dasatinib or nilotinib therapy, these mutations can be even traced back to the switchover sample. Also, there have been several examples, there have been several cases in which we could clearly see that low-burden mutations do expand if the patient receives the TKI these mutations confer resistance to. However, all these data come from retrospective studies and from studies performed in a relatively small subset of patients.